Okay, so I'm going to tell you about orphan symptoms and toxicities to the digestive tract. When we speak of such toxicities, this is a broad topic, just to get an idea of how broad it is. Just have a look at the gastrointestinal table of classification. So, of course, I'm not going to give you a catalog of all these toxicities. I've chosen to focus on two pathologies. One orphan symptom that we often come across with, that's hiccup. And one toxicity for the digestive tract, which we're not used to, that's colites that happens with immunotherapies. So what is the hiccup? That's repeated involuntary brutal contractions of the breathing muscle and shutting of the glottis. This is a phenomenon that goes on all along the life with contractions that are not consciously taking place. We say that it's an acute hiccup when it lasts for 48 hours. When it lasts for less, we say it's chronic, and we're looking for the causes. In oncology, a great percentage of patients have such hiccup. So we have the neurogastric nerve, the phrenic nerves that sent a message to the hiccup center, which is in the upper spinal cord and in the cerebral center. This is transmitted by the intercostal nerves and by the recurrent laryngeal nerve to the glottis muscle. Here, a problem that can happen at any stage of this reflex system can trigger hiccup, which is why you can have problems within the central nervous system, but you can also have metabolic systems. The most frequent reason for hiccups is the gastrointestinal is a gastrointestinal reason, and especially people who have stomach problems. We resort to corticoids. We use them often to prevent chemo-induced nausea. We know that this has an impact on a certain number of patients. This was proven by Lee, who tested patients who had such a problem. He stopped dexamethasone that was replaced by methylprednisolone. This shows the role of dexamethasone in hiccup as a stoppage comes along with the disappearance of hiccup as well. And the interest of this is also to show that when a patient cannot keep taking dexamethasone, we can go for methylprednisolone. Now, we know that hiccup is mostly triggered by chemotherapy. Any chemotherapy can induce hiccup, but it's mainly cisplatin and associated to dexamethasone. This triggers more hiccups, and there's a converse correlation with nausea and vomiting. And people who have nausea and vomiting don't have hiccup, and the other way around. Now, the refractory hiccup, it's important to have a checkup. It's important to look amongst the drugs which one can cause hiccup. You have to check also the earring and nose areas. the level biology, the level of urea, esophageal manometry. You have to check pH as well and have an MRI of the brain and a gastroscopy, because you need to identify one of the causes that I mentioned is quite frequently at the root of hiccup. So either the problem is digestive, and then you've got to go as far as esophageal manometric, or then you can turn to a neurological origin. What are the treatments? Here they are. The best one is treating the cause, which is why it's interesting to have an etiological checkup, which is why you see the inhibitors of proton pump and NTH2, which enable you to treat reflux and can improve significantly hiccups. The other treatments are purely treatments of the symptoms. Only baclofen and metoclopramide were validated through randomized trial versus placebo. And domperidone sometimes replaced metoclopramide. They have similar action, but they don't have the secondary effects, the side effects of metoclopramide. But this wasn't validated as domperidone. We only have clinical cases for the impact on hiccups. And for some others, we don't have actually randomized trials. Now, to conclude on hiccup, I think you will be given the slides after. So this is a summary of what you have to do. First, check up to identify the cause, to treat the cause first. If the cause is not established, try with an IPP treatment to try and have the symptom disappear. And if that's not enough, you can turn to baclofen, gabapentin, look for neurological reasons for the disease. Otherwise, if it's to do with the intestine tract, you can go for metoclopramide or chlorpromazine. Now, colitis, which happen when you have immunotherapy. Immunotherapies are new treatments that are well developed in cancer treatment approaches. So you have ipilimumab, which is a monoclonal antibody, anti-CTLA-4. So when you have receptors for the antigen cells, it has an inhibitor action, so it induces a tolerance phenomenon. When the CTLA-4 is blocked, you have an activation of T lymphocytes, which is going to enable these anti-CTLA-4 molecules to have their effect. That was validated especially for melanoma when you have ipilimumab associated to chemotherapy. The problem is that these overactivated lymphocytes are going to also tackle anti-tumoral molecules. So we're going to have thyroiditis, nephritis, pancreatitis, and hepatitis. So these are data for a cohort and a trial that we haven't published yet. This was about establishing the characteristics of these colitis. One remarkable point is that it is a side effect that can be seen quite early, 1 month after the beginning of the treatment, which means 2 injections of ipilimumab. Second point, severe colitis with abdominal pains, 8% in weight loss, which is quite significant. And you can see also serious complications with patients who had perforations, and some who actually died from this, one who died from such a lesion. Then there's the Crohn's disease. Here we see oral ptosis, pyoderma gangrenosum, and we've seen also anal problems. Here I showed you these two pictures, and colitis of the erythem, and on the other side, on the right-hand side, an erosive colitis. And we see some that are much more serious, and we can see how you can get to a digestive perforation state. This slide is a bit loaded, but what you have to remember is that the treatment of colitis through anti-CTLA4 is a corticoid treatment, and if it doesn't work, you have to use anti-TNF, which is something we commonly use for intestinal diseases. There's one thing that's not mentioned on this slide, that is in the cohort that we studied. We saw that there was a greater number of patients who got anti-inflammatory drugs and had colitis. This is worth noting because it means these are patients that for whom you should avoid resorting to such treatments. This is important when dealing with anti-CTLA4, and resorting to surgery as well is quite specific, because 15% of our cohort had to undergo surgery because they didn't answer positively to the medical treatment. And when this colectomy is carried out, you have to do it again. For some patients, the lesions are more severe, but you shouldn't hesitate in removing the most diseased part, because otherwise you might end up having other lesions, other abscesses, and we've had sometimes to resort to some specific measures after the colectomy. Now for colitis, again, these are severe forms in terms of vital prognosis. You shouldn't wait. If corticoids don't work, you have to go for infliximab, and if infliximab doesn't work, you have to move on to surgery extremely quickly. Otherwise, you might have to face complications. Therefore, you need highly specialized care for these patients. Thank you for your